Okay. Hello everyone. Very good evening to all of you. Yesterday we have done with the revision of gynecology, and today I am doing the obstetrics revision, and where I will be starting with the test and discussion. So I am just sharing the question paper with you, and the good thing is that it is live and you will get to understand that within the limited duration of time how you are supposed to read the complete questions and attempt the correct answers. Okay, if we give you paper beforehand, okay, then the point of this discussion will not be sorted out. Fine. So without delay, let us start with the obstetrics revision. Okay, I hope all of you are there, and I hope yesterday's session was useful to you. I have got many of the messages from the students that it was really very useful. Okay, so in today's session also, and many of the students have joined my Telegram group, and all the PDFs, key points, images, question paper I have shared in the Telegram group. Fine. Now I'm starting with the first question, that 35-year-old multiparous lady delivered vaginally. Okay. Doctor was trying to deliver the placenta by controlled contraction method but failed. Patient was shifted to operation theatre as she developed excessive bleeding. Doctor was trying to do manual removal of placenta but no success. What is the likely cause? Let me brief you once more. The lady is a multiparous lady and delivery of the baby has taken place. Now the placental delivery has to occur. So doctor was trying to take out the placenta by controlled contraction method but failed. Then patient developed excessive bleeding. That means it is third stage postpartum. Hemorrhage has occurred. Doctor shifted the patient to operation theatre and trying to do the manual removal of placenta but failed. Okay, what is the likely cause? Do you think it is placenta previa? Do you think it is PPH? Do you think it is abruptio placentae? Or do you think it is morbidly adherent placenta? Yes, I can see the correct answers. It is morbidly adherent placenta. Because in morbidly adherent placenta, what happens is that the baby has already delivered, and in this case the placental delivery is not being conducted and patient developed excessive bleeding. Now if you forcibly try to extract the placenta or forcibly try to find out or do the manual removal of placenta, what will happen? That there will be acute inversion of uterus. So what is morbidly adherent placenta? Where placental channels have invaded the superficial layer of the myometrium. This is placenta accreta. So in this case, the decidua basalis and Nitterbuck's membrane are absent. Okay, so in this case the management will be no other than hysterectomy. Since it is a multiparous lady, so the management of this case will be hysterectomy. Next. So I switch over to the question number 2. Identify the maneuver given in this image. Is it a McRoberts maneuver? Is it a Leopold's maneuver? Is it a Zavanelli's maneuver? Or is it a Pinard's maneuver? Just see the question carefully. what is the maneuver shown in the image? So I can see the correct answers. Most of you have marked it very correctly. It is Leopold's maneuver. In the Leopold's maneuver, the first grip is called as the fundal grip. The second grip is called as the lateral grip. The third grip is called as the pollic grip, and fourth grip is called as the pelvic grip. Okay. In the fundal grip, you can see soft fetal parts, which is non-ballotable, suggestive of breech. Second grip, you feel the fetal back. Third grip is the pollic grip, where you feel for the presentation. If it is a hard globular part, that is ballotable, which is called as cephalic presentation. If it is soft fetal parts, which is non-ballotable, then that is called as podalic or breech presentation. Fourth grip is for engagement. If your fingers are converging, that means the head is not engaged. If it is diverging, that means the fetal head has been engaged. Okay. So Leopold's maneuver, we apply these four grips to describe the lie and presentation. Okay. It is the longitudinal lie or it is the transverse lie. And if you have decided the lie, then what is the presentation? Is it a cephalic presentation or is it a podalic presentation? Cephalic presentation or it is a podalic presentation. Okay. So next, what is McRoberts maneuver used for? McRoberts maneuver is for treating the shoulder dystocia. Okay. Shoulder dystocia is a complication seen in macrosomia. Macrosomia is a large baby born to diabetic mother. Zavanelli maneuver is also to deliver shoulder dystocia. Okay, it is also to deliver shoulder dystocia. Pinard's maneuver is to deliver breech with extended legs. Okay, so McRoberts maneuver and Zavanelli's maneuver is to deliver the shoulder dystocia case, where the shoulder of the baby has got stuck up, only the head is born, and this is seen in macrosomia. Macrosomia is a large baby born to diabetic mother. Zavanelli maneuver is also for shoulder dystocia treatment. Pinard's maneuver is for breech with extended legs. Okay, so here the answer is Leopold's maneuver. Now, one of my question from you is, what do you understand by shoulder dystocia and shoulder presentation? Okay, what do you understand by the term shoulder dystocia and shoulder presentation? Shoulder dystocia is seen in macrosomia and shoulder presentation is a term used for transverse lie. In shoulder dystocia, shoulders are the one which is not delivering. In shoulder presentation, shoulder is the one which is delivering. So if you can see the difference in the two, this is head is born and the shoulders are the one which is stuck up. So this is shoulder dystocia. Okay, this is shoulder dystocia, that is macrosomia. and shoulder presentation is seen in transverse lie, where shoulder is the one which is deliver first. Okay, so you should understand the difference between the two things. Fine. So let us switch over to our next question. Anal sphincter tear is which degree of perineal tear, and when do you stitch a perineal tear? Fine. Now write down the answers in the chat box. Write down the answers in the chat box. That anal sphincter tear is which degree perineal tear? Answer is third degree. Why you're writing fourth? It is third degree perineal tear. Okay. First degree is mucosa and skin tear. Second degree is mucosa, muscle and skin tear. Third degree is external anal sphincter tear, and fourth degree is anal canal tear. So I have asked you the anal sphincter tear, which is third degree. Okay. Now you can see first degree is mucosa and skin, second degree is mucosa, muscle and skin, third degree is anal sphincter tear, and fourth degree is anal canal tear. Now timing to repair this tear. Always whenever a perineal tear occurs during the delivery, it is to be repaired immediately. This reduces the chance of infection and reduces the blood loss. Okay. If the patient comes late, then give antibiotics, and perineal tear is to be repaired after 3 months. Okay. Perineal tear is to be repaired after 3 months. This is very, very important point. First and second degree perineal tear is usually repaired in labor room under local anesthesia, and third and fourth degree perineal tear is repaired in the operation theatre under general anesthesia, and it should be taken as emergency. Fine. Now next. A lady was referred to the medical college from periphery. There is a history of home delivery by untrained personnel 2 weeks ago. On examination, it is complete perineal tear. When will you repair it? When will you repair it? Okay, I have just given you the answer. We will repair it after 3 months. We will repair it after 3 months. Now, next question. An intern conducts a delivery. Immediately after the delivery, the mother experiences the breathlessness, hypotension, tachycardia, and she collapses. Per vaginal examination is normal and there is no excessive blood loss. Most likely diagnosis. Is it postpartum hemorrhage? Is it DIC? Is it uterine inversion? Or is it amniotic fluid embolism? What is your answer? Yes. The answer, I can see all of you are marking it very, very correctly. It is the amniotic fluid embolism, when after the delivery, the patient has experienced dyspnea, she has hypotension, she has cyanosis, and she suddenly collapses. Now, if a lady has delivered a child and there is excessive bleeding and uterus is atonic, then it is atonic postpartum hemorrhage. Now, if the lady has delivered the child and there is patient has collapsed, collapsed and she is in shock, but the shock is out of proportion of blood loss. Out of proportion of blood loss, then it is uterine inversion. So I am telling you 3 questions. If a lady has delivered and there is excessive bleeding and uterus is not contracting, it is atonic, then it is atonic PPH. If a lady has delivered and she has collapsed, but why she has gone into shock and the shock is out of proportion of blood loss, then it is acute inversion of uterus. If a lady has delivered the child, there is breathlessness, there is hypotension, there is cyanosis, and there is suddenly collapse. If you see the uterus is contracted. If you see the episiotomy or the vaginal or vulval infection, vulval site, then there is no traumatic or atonic PPH. Okay, that you have already ruled out. Uterus is in its position and you can feel it in the suprapubic region. Then what is the reason for this collapse? Then there is some amniotic fluid embolism is suspected. Fine. Next, absolute indication for cesarean section: fetal distress, breach, minor degree placenta previa, or cancer cervix. So sometimes the questions are given in the big statements, sometimes it is in the single statement, but the answer is very, very confusing. So what is your answer in this question? What is your answer in this question? I can see many of you are marking different answers. That is what I said. When the statement is given, you are marking the correct answer. But when I am asking in the single liner, all of you are marking the wrong answers. Only few answers I can see. Fetal distress. Children, it is a relative indication for cesarean, because in fetal distress, you can conduct a forceps delivery. Okay, so it's a relative indication. For breech, you can do external cephalic version or you can do breech vaginal delivery. So again, it becomes a relative indication for cesarean. My question is absolute indication for cesarean section. Minor degree placenta previa. You can always conduct a normal vaginal delivery because that is not an indication for cesarean section, absolutely, because minor degree means type 1 placenta previa and type 2 anterior placenta previa. You can achieve the vaginal delivery. Okay. Next, cancer cervix. If there is a cancer cervix, there is the cancer cervix and there is a baby. In this case, you cannot conduct the vaginal delivery because head striking, the patient will start bleeding. Okay. In this case, depending upon which stage of cancer your patient is, if it is early stage cancer, then you have to go for a classical cesarean section. Classical cesarean section followed by hysterectomy if it is early stage cancer like stage 1. Okay. If it is advanced cancer, then irrespective of the period of gestation, okay, if suppose it is stage 3 cancer, then you cannot wait for the baby to continue the period of gestation. Means you cannot wait for baby to mature and conduct the delivery and then perform the treatment. No, because life of the patient is more important. In that case, keeping the baby inside irrespective of the period of gestation, you will give concurrent chemotherapy. Okay, maybe it will lead to fetal death, doesn't matter, but safety of the life of the patient is our first priority. So more details will be for postgraduate interest. Cancer cesarean in pregnancy, what is the management? Okay. Now my question is, if you're seeing the female for the first time in the antenatal clinic and she is 20 weeks pregnancy, Your patient asks you, doctor, can I go for a screening of cancer cervix? Can the pap smear be done in that setting? What is your answer? Yes or no? She is 20 weeks pregnant and she has heard some awareness talk by the doctors or somewhere from the social media she has seen, and she is asking, doctor, can a pap smear be conducted on me as she is pregnant? Answer is yes, because you are taking a pap smear from the lip of the cervix and cervical canal. Without disturbing the pregnancy, a pap smear can be conducted easily. Okay. Now, my question is, vaginal delivery is allowed in all except, okay, twins with first baby vertex, monoamniotic, monochorionic twins, breech or face presentation. So, vaginal delivery can be allowed in all of the following conditions except one condition where you would like to do a cesarean section. What's your answer? I can see some of the students marking it very correctly. I could see in yesterday's session more and more correct answers were there. So is it that gyne is more easy for you and in the obstetrics you're getting confused because I'm getting different answers? Okay. In this question, straight away they are asking, what is the indication for cesarean section? When it is a twin with first baby breech, you can allow a normal vaginal delivery. When it is a breech presentation, you can allow breech vaginal delivery, or you can do external cephalic version and make it vertex. Okay. Face presentation, normal vaginal delivery can be allowed. Now, one more point to elaborate in this case. One more point to elaborate in this case is we have to see. Now, this I have been telling in my sessions that bispinous diameter, the distance between two ischial spines is 10.5 centimeters. This is called as interischial diameter, and this is the level where internal rotation of fetal head takes place. Internal rotation of fetal head takes place so that occiput lies behind the symphysis pubis and delivery can be conducted. Occiput lies behind the symphysis pubis and delivery can be conducted. Okay. So, in cases of first baby vertex, the diameter is 9.5. So, any diameter of the fetal presenting part, any diameter of less than 10.5 will deliver. So, in vertex, it is 9.5. Okay. In breech, the diameter is 10. In face presentation, it is 9.5. So, it is monoamniotic, monochorionic. Why we want to conduct the cesarean section in this case? Okay. In monoamniotic, monochorionic twins, okay, there is a single amnion, okay, and single chorion. Single amnion and single chorion. So there are two babies, and they are sharing a single placenta. Okay, so this is monoamniotic, monochorionic twins, and the risk is twin-twin transfusion syndrome. So in this case, we have to deliver them by elective cesarean section. So that is why our question changes to monoamniotic monochorionic twins because of the risk of twin transfusion syndrome. Next, all of the following can be seen in polyhydramnios except this question which I have asked is an AIMS PG question. So I am making you prepare for a tougher aspect and I am giving you concept based questions as well as single liners. Single liners आपने अच्छे से already revise कर रखे हैं, तो मैं image based questions and concept based questions यहाँ पे डाल रही हूँ, ठीक है, so that if there is any deviation, okay, इस क्वेश्चन का ये आंसर है, इस क्वेश्चन का ये आंसर है, that is not revision, that you are already perfect. That batch which I have taken, the students are able to mark it very correctly. But यहाँ पे last moment, ये last final revision चल रहा है, तो I have to introduce concepts in you so that जब भी आप questions देखें exam में, you should not get deviated and you should get a habit कि teacher ने कैसे बताया, madam कैसे बता रही है, एक एक point को rule out करो and you will get the correct answers. Fine. Next. So all of the following are seen in polyhydramnios and I promised my students when I will be taking the revision or the rapid revision, I am going to touch up the topics which we are not able to cover up in the classes, but in the exam the questions are being asked. Okay. My Telegram channel is Dr. Harmeet Goel Telegram channel. I will ask Dr. Shibu to share the Telegram link and I told the students to share the link in the chat so that everybody is able to, join the group. Okay. So all of the following can be seen in polyhydramnios except before I end up the session, I will ask the staff to share the link so that you can join. Okay. So what is the answer to this question? All of the following can be seen in polyhydramnios except postpartum hemorrhage, abruptio placentae, obstructed labor or cord prolapse. What is your answer? See, polyhydramnios means huge liquor. Okay, the abdomen of this pregnant lady, the uterus is distended. Okay, it is distended and amniotic fluid is more than 2 liters on ultrasound, or amniotic fluid index is more than 25 centimeters, or single deepest liquor pocket is more than 8 centimeters on ultrasound. This is the definition of polyhydramnios. Amniotic fluid more than 2 liters on ultrasound, or amniotic fluid index more than 25 centimeters, or single deepest liquor pocket is more than 8 centimeters on ultrasound. So polyhydramnios, there is always a tendency for preterm labor pains, and when there is sudden seepage of the liquor, the placental abruption can take place. So this is a complication which can occur. Then cord prolapse can occur because if there is sudden rupture of the fetal membranes, the umbilical cord is very unsupported because fetal presenting part is floating up in the abdomen. ठीक है, fetal head नीचे नहीं आता है, इससे पहले ही amniotic fluid rupture हो जाता है and umbilical cord can easily prolapse. Okay, so cord prolapse is also a very known complication of polyhydramnios, and after the delivery uterus fails to regain its normal tone, so it lands up in PPH. So obstructed labor cannot occur because this pregnancy cannot go post-dated. ठीक है, हमेशा टेंडेंसी रहती है प्री टर्म लेबर पेन्स की, प्री मेच्योर रप्चर ऑफ मेम्ब्रेन्स की, पोस्टपार्टम हेमरेज, एब्रप्शियो प्लेसेंटे, कॉर्ड प्रोलैप्स, बट ऑब्स्ट्रक्टेड लेबर नहीं होगा क्योंकि ये प्रेगनेंसी पोस्ट डेटेड तक जाएगी ही नहीं. कैन दिस प्रेगनेंसी क्रॉस 40 वीक्स? अनलाइकली. In my career, I have done my MBBS from Lady Hardinge Medical College and post graduation from Safdarjung Hospital and the senior residency. I have not seen any patient of polyhydramnios developing obstructed labor or going post-dated. Similarly, for the twins, they can never go post-dated. There is always a tendency for preterm labor pains and premature rupture of fetal membranes. So this is the question of FMG. And it is very untouched part. ये question usually discuss होता नहीं है, but it can come in the exam. ठीक है. So again students revise what is polyhydramnios. Amniotic fluid more than 2 liters on ultrasound. Amniotic fluid index more than 25 centimeters on ultrasound. Single deepest Leica pocket more than 8 centimeters on ultrasound. Now in this polyhydramnios, you should know that normally what happens, fetal urine contributes to the formation of amniotic fluid. So during the intrauterine life, baby keeps on secreting the liquor and baby keeps on drinking the liquor. Okay, keeps on secreting the liquor and keeps on drinking the liquor. So what are the important causes of polyhydramnios? Important causes of polyhydramnios is the fetal causes like open neural tube defects, like anencephaly, where there is more fluid release from the open meninges. Then there can be tracheoesophageal fistula. Tracheoesophageal fistula, because there is a defect in drinking of the liquor. Or maternal diabetes. Maternal diabetes can also lead to a condition called as polyhydramnios. Now, next question. I am trying to test your knowledge in this question. Gravida 5, Para 3, L3, A1. Whenever I have taken the live sessions, maximum students have marked it very wrong. So G5, P3, L3, A1 presented with active labor pains. Okay, patient is in active labor. On examination, there is cervix 5 centimeters dilated. Many of the questions I have newly created. ये क्वेश्चंस आपको कहीं पे नहीं मिलेंगे क्योंकि काफी सारे क्वेश्चंस मैंने खुद से प्रिपेयर करे हैं, सो एज टू गिव यू वेरी कॉन्सेप्ट्स so that आप एग्जाम में मिस्टेक्स ना करें, बिकॉज ऑब्स गायनी इज अ वेरी सिंपल सब्जेक्ट, प्रोवाइडेड आप अपनी नॉलेज जो है वो उसमें अप्लाई करें करेक्टली, तो आपके आंसर्स कहीं नहीं गए हैं. एंड आई हैव सीन 90% ऑब्स गायनी क्वेश्चंस अगर स्टूडेंट्स पढ़ के गए हैं, दे कैन मेक इट करेक्टली. So in this case, vertex presentation and there is a cord prolapse. There is a cord prolapse. Important thing is cord pulsations are not felt. So what is your most appropriate management? Do immediate ultrasound to check for the umbilical cord pulsations. Shift for immediate cesarean section. Wait and watch or start the oxytocin drip. देखो मैंने काफी सारे नए क्वेश्चंस क्रिएट करे हैं और मैं देख रही हूँ हर एक स्टूडेंट के आंसर अलग अलग आ रहे हैं. वही तो है ना, अगर आप नए क्वेश्चंस देखते हो एग्जाम में तो आप कंफ्यूज हो जाते हो और आप अलग अलग आंसर्स मार्क करते हो. तो वही मैंने देखा, बल्कि कल के डिस्कशन में गायनी में इतने डेविएशंस नहीं थे आंसर्स में. मैक्सिमम ऑफ यू आर एबल टू मार्क इट करेक्टली. और आज के मैंने डिस्कशन में देख रही हूँ काफी लोगों के आंसर्स. तो इट्स गुड थिंग दैट यू आर अटेंडिंग द सेशन लाइव. ठीक है, दैट यू आर अटेंडिंग द सेशन लाइव. सो फ्रेंड्स, सबसे पहली चीज क्या है, दिस पेशेंट इज अ मल्टीपैरस लेडी. मल्टीपैरस लेडी एंड कॉर्ड प्रोलैप्स में कॉर्ड पल्सेशन एब्सेंट का मतलब होता है डेड फीटस. सो इसमें कभी भी एक्टिव लेबर पेन में हम उसको अल्ट्रासाउंड के लिए नहीं भेजते. मल्टीपेरस लेडी है, जब ऑलरेडी डेड फीटस हो गया है तो हमें सिजेरियन भी नहीं करना है। ऑक्सीटोसिन ड्रिप का कोई रोल ही नहीं है बिकॉज पेशेंट इज ऑलरेडी इन एक्टिव लेबर। जब एक्टिव लेबर पेन्स में है तो उसके ऊपर सुपर एक्टिव तो कोई टर्म ही नहीं होती, ठीक है। सो ऑलरेडी द पेशेंट इज इन एक्टिव लेबर, सो देयर इज नो टर्म कॉल्ड एज सुपर एक्टिव लेबर, फाइन। सो देयर इज नो रोल ऑफ स्टार्टिंग इन ऑक्सीटोसिन ड्रिप। इसमें कुछ नहीं करना है आपको, सिंपली वेट एंड वॉच फॉर अ नॉर्मल डिलीवरी बिकॉज दिस बेबी हैज बिकम डेड। Cord pulsations absent means it is a dead fetus. Okay, so you don't have to send the patient for an ultrasound to confirm. कभी भी active labor patient को हम ultrasound के लिए नहीं भेजते. Okay, that is even if it is a placenta previa, you never send the patient for an ultrasound. Fine. So it is wait and watch. Next. Weight of the uterus immediately after delivery. This is a very straight question from FMG exam. So to boost your confidence also, I am asking the FMG exam questions as well. So weight of the uterus immediately after delivery. I think everybody is going to mark 1000 grams. What is the weight of the non-pregnant uterus? What will you mark? Weight of the non-pregnant uterus. Weight of the non-pregnant uterus, what you will mark? Weight of the non-pregnant uterus is 60 grams. Weight of the non-pregnant uterus is 60 grams. Okay. Lochia. Lochia means shedding of decidua. So what is the normal duration of lochia and what is the correct sequence of lochia? What is the normal duration of lochia and what is the correct sequence of lochia? Normal duration of lochia is 3 weeks. Normal duration of puerperium is 6 weeks. ठीक है, puerperium is 6 weeks. So what is the sequence of lochia? Is lochia rubra, serosa and alba. Lochia rubra, serosa and alba. Normal amniotic fluid index. Normal amniotic fluid index. What is your answer? Some new questions I have created. Some new questions I have created for you. कि रटे रटाए questions तो आप कर ही लेते हो, मुझे पता ही है. So yes, I am happy that all of you are marking the correct answer. It is 5 to 25 centimeters. If AFI is less than 5 centimeters, you call it as Oligohydramnios. And if AFI is more than 25 centimeters, you call it as Polyhydramnios. Okay? You call it as Polyhydramnios. Now, what is the color of the amniotic fluid at term pregnancy? Answer is pale straw color. Color of amniotic fluid at term pregnancy is pale straw color. Pale straw color. And when is a maximum amniotic fluid? Answer 32 weeks. It is maximum 1 liter according to Williams. And at term pregnancy, how much is the amniotic fluid? Answer is 600 to 800 ml. 600 to 800 ml according to the textbook Williams. Okay. So amniotic fluid index is 5 to 24 centimeters. This is according to Williams textbook. Single deepest Leica pocket is 2 to 8 centimeters. And you can see in the image, this is the amniotic fluid volume on ultrasound and this is the single deepest Leica pocket. Okay. Now, what is the presentation when the attitude of the fetal neck is partial extension? So what will be the fetal presentation? This is a question being already asked in FMG exam 2015. So you have to tell me, if the attitude of the fetal neck is partial extension, what is the presentation and what will be the engaging diameter? Here the answer is none. I have forgot to type the exact answer. What is the exact answer? For partial extension, the presentation is broad and the engaging diameter is mento vertical, which is 14 centimeters, and this cannot deliver. So management is cesarean section. So attitude of fetal neck. Attitude means relationship of different fetal parts to each other. If the attitude of the fetal neck is complete flexion, then it is vertex, which is the presentation, and the denominator is occiput. If the attitude is partial extension, it is broad presentation. Okay, and the baby will not deliver because engaging diameter will be mento-vertical, which is 14 centimeter. If the attitude is complete extension, it is the face presentation. Mentum is the denominator and the diameter is submento-brachmatic. Okay. This question we have discussed. Which of the following condition requires a serial determination of pregnancy test? So it is a molar pregnancy. In yesterday's session, we have already discussed this particular point. Now, I have a question for you, and please make it a point, itne long statement questions do expect in your exam. But the great thing is you have complete December and mid of the January to make the revision as perfectly as possible. Take it this as your last exam of FMG. ठीक है, इस एग्जाम को निकालो, and I sincerely hope that all the students should pass their exam. Okay, so long statement questions जरूर expected है, so please make it your habit to read और उसमें से important points को grasp करो and mark your answers. So मैंने clinical question पूछ रही हूँ. 28-year-old female primary gravida was admitted in the labor room with labor pains. She is 36 weeks of pregnancy. Blood pressure is 170 by 110. CTG. CTG is cardiotocography. When we want to see that intrapartum fetal surveillance, that during contractions the fetus is receiving enough of the blood supply and this contraction should not affect the fetal heart. So we put in a CTG where there is a bed and there's a monitor and we can see the fetal heart rate in relation to uterine contraction. There should not be any deceleration. That is what is CTG. So doctor is monitoring the contractions. We put our hand onto the abdomen of pregnant lady and we check for uterine contractions in 10 minutes time. Okay. And patient, since it is the PIH case, so doctor has started the patient on antihypertensives and ordered all the necessary investigations for preeclampsia like complete hemogram, peripheral smear, liver function test, kidney function test, urine proteins and fundus examination. So all the investigations has been ordered. During this time the patient threw a fit, मतलब उसको convulsions आ गए. So IV line started and magnesium sulfate loading dose is given. Loading dose is IV plus IM. So total dose of magnesium sulfate is 4 gram plus 10 gram is equal to 14 gram. IV plus IM. So magnesium sulfate has been started. Patient was catheterized. Now what will be your next line of management? एक पेशेंट लेबर रूम में एडमिट हुई विद लेबर पेन्स, उसका ब्लड प्रेशर 170 बाई 110 है. ऑल द इन्वेस्टिगेशंस वर सेंट, एंटी हाइपरटेंसिव्स वर स्टार्टेड एंड सीटीजी वाज पुट ऑन क्योंकि देयर इज द चांस ऑफ फीटल लॉस. एक तो सिवियर प्री एक्लैम्सिया है, ठीक है, But during this management time, patient has thrown a fit. Okay, so magnesium sulfate loading dose has been given IV and IM, and I think catheterization must have been done. Now, what is your next plan of management in this question? Are you going to do immediate cesarean section? Because termination has to be done. Once you start the patient on magnesium sulfate, you have to plan the termination of pregnancy. Okay, so immediate cesarean section. I don't think, because first you have to stabilize your patient. Wait and watch and continue till 36 weeks, 38 weeks. जब patient को convulsions आ जाते हैं तो उसमें कभी continuation of pregnancy नहीं होता. ठीक है? Continue magnesium sulfate, assess for induction of labor or LSCS, control the blood pressure, stabilize, shift to the ward and discharge the patient. कभी भी convulsions के patient को discharge नहीं करते, कभी भी immediate cesarean नहीं करते. सबसे पहले आपने जब मैग्नीशियम सल्फेट दे दिया, एंटी हाइपरटेंसिव दे दिया, तो अब आपको क्या करना है? यू हैव टू डिसाइड द मोड ऑफ डिलीवरी. Mode of delivery in this case can be a cesarean section, that you will do the pelvic assessment, cervix is closed or it is open, and you can do induction of labor by doing oxytocin or ARM, and you can even conduct the forceps delivery. So continue magnesium sulfate and assess for induction of labor or cesarean section. So D is the correct answer. You cannot go for cesarean just like that blindly, because जब भी किसी patient में high blood pressure होता है, उसमें blood loss का chance बढ़ जाता है. So there is a chance of postpartum hemorrhage. So doing a cesarean is also not easy. Now, what is a choice? What is a choice of anesthesia? You are planning to do a cesarean section in PIH patient. So when you're planning to do a cesarean section in PIH patient, the choice of anesthesia in this case is epidural. Epidural anesthesia, because to control the blood pressure is easy in cases of epidural. Now, all of the following are markers for triple test done for screening of Down syndrome except. So triple test is very commonly asked question, and I don't think there will be anybody who can make up a mistake in marking this answer wrong. So all of the following are markers for triple test for screening of Downs except. I think everybody is right. So it is Papa. Papa is a first trimester marker. So when it comes to the first trimester screening, it is a double screening. You take the blood sample and you do beta HCG plus Papa, that is pregnancy associated plasma protein. Beta HCG increases and Papa decreases, and you get an ultrasound done at 11 to 14 weeks to check for the nuchal translucency. 11 to 14 weeks to check for the nuchal translucency. If nuchal translucency is more than 3 mm, this is abnormal. So if you combine the two tests, 87% predictability that this baby is Down. So all of you know the triple test markers, and if you talk about the fourth marker in quadruple test, the fourth marker in the quadruple test is inhibin A, which is elevated. So all of you are aware of this triple test markers. Now next question. A 36-year-old female was brought to the hospital in active labor. She is gravida 5, para 3 L3A1 with 9 months pregnancy. Her pulse rate is 110 per minute. BP is 90/50. Now, why this patient is in hypotension? Per abdomen, the fetal parts are felt very prominent and fetal heart rate is not localized. Cervix is fully dilated, but fetal presenting part, instead of down, it is felt higher. Fetal presenting part, instead of down, it is felt higher. Now, what is your management? First of all, what is your diagnosis? Number 2, what is your management? You can write down your answers in short. So, I can see Sneha, Yash, Rohit, Alia. Okay. They are marking it very, very correctly. So it is clear-cut case of obstructed labor and rupture uterus. Rupture uterus. It's not that in primigravida the rupture uterus occurs. Even in the multigravida, the rupture uterus can take place because of the size of the baby and because of the grand multipara. The sensitivity of uterus to oxytocin is being increased. So in this case, no wait and watch, just take the patient for straight cesarean section, because any type of obstructed labor, fetus is dead or alive, you have to do a cesarean section. This plenty of times I have told that any type of obstructed labor, any type, even if the fetus is dead, your management is always immediate laparotomy followed by cesarean section. And if it is a rupture uterus, if you can repair it, better repair it. If it is a multiparous lady and usually the uterus is in bad shape, so we prefer doing a hysterectomy in the same sitting. Okay. Now, one thing which we have not discussed in the classes is what is Bandel ring, what is constriction ring. What do you understand by Bandel ring versus constriction ring? This is the topic given in your textbook. Okay. Bandel ring is also called as pathological retraction ring. Bandel's ring is also called as pathological retraction ring, and Bandel's ring is formed in obstructed labor. This Bandel's ring is formed at the junction of upper and lower uterine segment. Okay, and you can see this Bandel's ring per abdominally with your naked eyes. Okay, and this is a feature of obstructed labor. Management is always a cesarean section, whereas constriction ring is also formed at the junction of upper and lower uterine segment. It is over judicious use of oxytocin. There is a ring formation. There is a ring formation which is constricting the neck of the baby, So the relaxants are used which can release this. But constriction ring you cannot see with your eyes. You can see it when you are doing a cesarean section. There's the ring constricting the neck of the baby. Okay. So that is what is the Bandel's ring and constriction ring. Now, a woman was referred from primary health center with prolonged labor. She is now being taken up for cesarean section for fetal distress. Which of the following is the correct position in which the nurse should keep the patient on the operation theater table? Trendelenburg position, supine position, semi-Fowler's position, or supine position with wedge placed under the right hip? So I am again revising this question because this is a question which has been asked in FMG exam and it is an important question, I feel. So you must revise this question. Yes. So I have already explained the supine hypotension syndrome. I have already explained the supine hypotension syndrome. Supine hypotension syndrome, where if the lady is lying down in the supine position, okay, if the lady is lying down in the supine position, what happens? There is an inferior vena cava and inferior vena cava get compressed. Okay, already there is a gravid uterus compressing upon the inferior vena cava. So maximum females, the collaterals open up and nothing happens to the patient. In some patients, the collaterals fails to open up. So patient has a feeling of hypotension, tachycardia and syncope. So hence, always the pregnant ladies are advised to lie down in the left lateral position to avoid this supine hypotension syndrome. So when you're doing a cesarean section, if the patient is lying in the supine position, naturally the inferior vena cava will get compressed and the blood supply to the patient will be reduced, and she has a feeling of hypotension, tachycardia and syncope. Okay, and already when a cesarean section is done under spinal anesthesia, the most common side effect of spinal anesthesia is hypotension. The most common side effect of spinal anesthesia is hypotension. So one is already there is a low blood pressure. That is why when you're taking up the patient for cesarean section, the doctor says that infuse at least the 1 liter of normal saline so as to avoid this supine hypotension syndrome and hypotension as a side effect of spinal anesthesia. So this is something which is important. So I have already discussed this particular point, that patient should be put in a lying down posture where a wedge is put under the right hip so as to give a tilt to the left side so as to avoid the supine hypotension syndrome. A lady comes with 12 weeks pregnancy presenting with bleeding per vaginum. On examination, cervical os is open, but no products have come out. What is your diagnosis? Os is open, but no products have come out as yet and there is bleeding. What is the type of abortion and what is the management? Yes, this is clear-cut and inevitable abortion. This is clear-cut and inevitable abortion. Okay, clear-cut, inevitable abortion. ठीक है? So what is the management of inevitable abortion? Management of inevitable abortion is DNE, dilatation evacuation, using the ovum forceps followed by curettage. Followed by curettage in the same sitting. Now next, a 32-year-old lady has delivered a female child of 3.2 kg, placenta delivered intact, and she went into atonic PPH. What are the important steps in management? All are done in immediate period except. Okay, she has gone into atonic PPH. All of the following steps are to be done except. All of the following steps are to be done except IV fluids, injection oxytocin in the IV drip, tablet misoprostol sublingual, or shift for hysterectomy. What is your answer? Yes. I can read Dr. Yash, Dr. Nazim, Dr. Veera, Dr. Mohammed, Dr. Ronit, Dr. Himanshu, Dr. Ramesh, all of them are correct. Yes, we are going to start the IV fluids, and the best fluid is ringer lactate drip or normal saline drip. We give injection oxytocin in the IV drip because oxytocin, the onset of action is fast, okay, and it is a drug to manage the atonic postpartum hemorrhage. Then tablet sublingual prostaglandin E1 is to be given, okay, to treat the atonic PPH, but shift for hysterectomy is not done because after you go, there are 3 steps in managing the atonic PPH. First is the medical steps, which is already been written in this question. Next is the mechanical steps where Bakri balloon tamponade, that is compression hemostasis, and third is the surgical steps. In the surgical steps, we go for devascularization, that means uterine artery ligation, ovarian artery ligation. Then we go for Bielin's sutures, okay, B-Lynch sutures, and then final step is the hysterectomy. Fine. So I don't think anybody is going to mark the rule out that option. So hysterectomy is never done in this case. Okay, unless until you have no choice than to save the patient. Now, anti-epileptic with least teratogenic effect in pregnancy. Okay, anti-epileptic with least teratogenic effect. I'm just making it a revision for you. So that is why again and I'm asking this question. So I hope everybody remembers I've been discussing in my classes. So the answer is levetiracetam, and next is lamotrigine, which is a drug which has got maximum teratogenic effect. So maximum teratogenic effect is sodium valproate. Maximum teratogenic effect is sodium valproate. Next, a 34-year-old female admitted in the labor room with history of G3P2L2 with 36 weeks of pregnancy, pain abdomen, vaginal bleeding. On examination, pulse rate is 100 per minute, BP is 150 by 100, per abdomen uterus is 36 weeks, tender uterus. PIH. Tender uterus PIH, I think what I am trying to explain is Abruptio placentae. It is diagnosis is PIH with Abruptio placentae. When it is Abruptio placentae, you have to conduct the delivery. There is no wait and watch. This I have already explained in my sessions. Okay. There is no wait and watch. You have to conduct the delivery. So PIH, Abruptio is a known complication. In PIH, Abruptio is a known complication, and if Abruptio occurs, that means you have to switch over to the delivery. Okay. And if the blood pressure of the patient is maintained, the pulse rate is maintained, the general condition is fair, there is no harm in going for a normal vaginal delivery. You augment the labor by doing oxytocin or ARM. So admit and cesarean. No, I am not in favor, because patient is already in active labor. When she is already in active labor and there is bag of water formation, so clear cut, try to search ARM in the question. ठीक है, जहां पे बैग ऑफ वाटर लिखा है, जहां पे 4 या 5 सेंटीमीटर्स ऑफ सर्वाइकल डायलेटेशन लिखा है, वहां पे स्ट्रेट अवे सर्च फॉर ARM, आर्टिफिशियल रप्चर ऑफ मेम्ब्रेन्स यूजिंग अ कॉकर्स आर्टरी फॉरसेप्स. दैट मीन्स यू आर गोइंग फॉर सर्जिकल ऑगमेंटेशन ऑफ लेबर. सर्जिकल ऑगमेंटेशन ऑफ लेबर. ऑगमेंटेशन का मतलब क्या है? यू वॉन्ट टू इंक्रीज द लेबर. इसको इंडक्शन नहीं बोलते, बिकॉज इंडक्शन का मतलब है सर्विक्स क्लोज्ड, और ऑगमेंटेशन का मतलब है you are increasing the contractions so that fast delivery can be conducted. So observation is wrong. Start oxytocin drip is wrong when there is a bag of water. Do ARM. Okay. So answer to this question is B, admit. Arrange for blood because you might require any blood. Okay. Then do ARM and watch for progress of labor. Anytime the fetal heart starts dipping down, bleeding is not getting control, bleeding increases, you can switch over for emergency cesarean section. Next, 32-year-old female with G2P1L0. Okay, so there is no live issue, and 36 weeks of pregnancy is admitted in the labor room with 150/100 blood pressure. So she is a case of PIH. She is a case of PIH. Previous ultrasound showed IUGR, यानी कि इसमें IUGR है. ठीक है, with IUGR. IUGR is a known complication in PIH because already there is vasoconstriction. So growth of the baby is affected. Okay, so fundal height is 34 weeks. Fetal heart rate is present. Ultrasound Doppler was conducted and it is done on umbilical artery. Okay. What do you see in this image? Is it a normal blood flow pattern? Is it absent diastolic blood flow, or can you see the reversal of diastolic blood flow? Even if the fetal heart rate is in normal limits, Dr. Nabi, ARM is to be done. ARM is mostly recommended in abruptio placentae patient. Okay. So I can see Dr. Mahesh, Dr. Vikas, Dr. Bharat, Dr. Arshil, Dr. Rahul, Dr. Ramesh, Dr. Janki, Dr. Anju, Dr. Mohammed. So everybody is right. This is reversal of diastolic blood flow within 24 hours. The pressure is so high that the blood supply, instead of going to the fetus, it is in the reverse direction. So you have to conduct a Caesarean section in this case, seeing at this kind of Doppler. Okay, because this baby is going to die within 24 hours. So no wait and watch, do Caesarean section. All the drugs are contraindicated in pregnancy except valproate, propyl thiouracil, radioactive iodine, or warfarin. Valproate causes teratogenic effect. Radioactive iodine is not given in pregnancy as it causes congenital malformation. Warfarin also causes congenital anomalies. So, propyl thiouracil is safe in pregnancy. Hormone secreted by Leydig cell. सो ऐसा नहीं है कि मैंने सारे ही कॉन्सेप्ट बेस्ड या लॉन्ग लॉन्ग क्वेश्चंस लिख दिए, मैंने बीच में सिंपल क्वेश्चंस भी डाले हैं सो एज टू बूस्ट अप योर कॉन्फिडेंस लेवल. ठीक है. सो हार्मोन सिक्रेटेड बाय लेडिक सेल, दिस इज एन एफएमजी क्वेश्चन. सो आंसर इज टेस्टोस्टेरोन. Mullerian inhibiting substance, androgen binding protein, and inhibin. This is secreted by Sertoli cells. This is secreted by Sertoli cells. Basal metabolic rate in pregnancy increases by 25%. Basal metabolic rate in pregnancy increases by 25%. Which of the following is seen in first stage of labor? Includes all except first stage of labor. Try to revise. First stage of labor. Yes, yes. All of you are correct because students often get confused in this. Expulsion of the fetus is second stage of labor. Increase in contraction and cervical dilatation is first stage of labor. And delivery of placenta. Delivery of placenta is third stage of labor. Delivery of placenta is third stage of labor. Third stage of labor. So, in first stage, uterine contractions, cervical dilatation. Second stage, delivery of the baby or expulsion of the fetus, one and the same thing. And third stage is delivery of the placenta. What is the cutoff value of plasma glucose in case of glucose challenge test done for screening of diabetes? What is your answer? In this question, what is your answer? So answer is 140. So nowadays, glucose challenge test or screening of diabetes is done by DIPSI criteria. Diabetes in Pregnancy Society of India. diabetes in pregnancy. ठीक है. In this case 75 grams of glucose is given and blood sugar is taken after 2 hours. The cutoff value is less than 140 milligram percent. Okay. Now, what is GTT? GTT क्या? Glucose tolerance test. Glucose tolerance test, 75 grams of glucose is given. That is International Association of Diabetes in Pregnancy Study Group. ठीक है. So fasting 1 hour, 2 hours. Fasting cutoff value is 92. ठीक है. 1 hour is 180 and 2 hours is 153. So this was asked in AIMS PG, the GTT. And in MCI, they have asked about the DIPSI criteria. What is the cutoff value? DIPSI criteria, what is the cutoff value? Now, 35-year-old lady, G3P0L0A2. That means she has 2 abortions. There is no live baby and she is already 35. She presented with 16 weeks of pregnancy. Previous abortion has occurred at 4 months. Now she has pain and ultrasound showed funneling of cervix and cervical length is 21 mm. So what is normal cervical length? Normal cervical length is 25 mm. So it is cervical length shortening. So what is your diagnosis? Your diagnosis is cervical incompetence. Okay, cervical incompetence, which is responsible for second trimester abortion. So 2 abortions has already taken place. Third time your patient is pregnant. And in this case, she also started with pain abdomen and this pregnancy is also about to abort. Okay. So what is your best management? You want to save this pregnancy. What is your best management? The cervix is already opened up. Cervical length shortening has already taken place. So what you want to do? You want to prolong the pregnancy. So you tighten the cervix with the help of a non-absorbable suture. This is called as cervical encerclage operation. Okay. And the best cervical encerclage operation is McDonald stitch. And your patient should be on bed rest and you have to give tocolytic agent, which is the best tocolytic agent is nifedipine. Okay, tocolytic agent is nifedipine. So in this case, apply McDonald stitch. No need for Cerviprime gel because you're not going to do MTP. Okay, you're not going to terminate pregnancy. No role of misoprostol because you don't want to abort this pregnancy. These are abortifacient. And no need to give steroids. What is the best time to give steroids? Steroids are given to cause lung maturity. The ideal time to give steroids where you are suspecting a preterm delivery. So you want the fetal lung maturity. What you want? You want the fetal lung maturity. So in that case where preterm labor pains have started, you want to give steroids. So what is the ideal time for steroids? Best time for steroids is between 30 to 32 weeks of pregnancy. Ideal time for giving steroids for lung maturity is at 30 to 32 weeks of pregnancy. Even steroids are affected at 32 to 34 weeks of pregnancy. Less than this, there is lung hypoplasia. More than this, lung maturity has already been attained. So this is the ideal time for giving steroids. And what are the types of steroids that we give? We can give dexamethasone or we can use beta-methasone. These are the steroid injections we need to give. And steroids to add, it requires 24 hours. So if delivery is conducted after 24 hours of steroid injection, then that is the best one. Now, what is the engaging diameter in this presentation? First of all, first you have to diagnose what is this presentation. What is this presentation? And then you can write down the diameter. Such questions are expected in your exam. They can ask you such questions. Yes, you can see this is the occiput. So it is not vertex presentation. And you can see the brow is also behind. So what you can see, I can see the face presentation. So this is the face presentation. So engaging diameter is submentobrachmatic, which is 9.5 centimeters, and that is what is the face presentation. Mentovertical is for brow presentation. Suboccipitobrachmatic is for vertex presentation, 9.5. Brow is 14 centimeters, and suboccipitofrontal is some other diameter. Okay. Next, all of the following are important indications for MTP except. All of the following are important indications for MTP except. This question has been asked in 2020 FMG, but I have changed the options so that a new question can be created. Is it a condom failure? Is it a rape victim? Mother having serious medical disease? For example, she has malignant retinopathy, or she has malignant hypertension, or she has grade 3, grade 4 heart failure. Okay? Or she is having a twin pregnancy. Which do you think is not an indication to perform a cesarean section? Which of the following is not an indication to perform cesarean section? Well, your answer is twin pregnancy. Okay, twin pregnancy nowhere is an indication to perform cesarean section. Nowhere is an indication to perform cesarean section. Okay. Now, a lady has presented with recurrent abortions at 8 weeks, 11 weeks, 22 weeks. She also had preeclampsia in the last pregnancy. Cardiac activity of all 3 pregnancies were normal. Okay. Which of the following is the most probable cause? So, structurally and functionally, these fetuses were normal. So, there was structurally and morphology of these fetuses were normal, but they aborted. Okay. So when it is structurally and morphologically normal, you can rule out chromosomal abnormalities. So there is no chromosomal cause for this. Okay. There is no chromosomal cause for this. Okay. And there is the history of PIH in the previous pregnancy. So what do you think is the cause? The cause is APLA, that is antiphospholipid antibody syndrome. Antiphospholipid antibody syndrome, and we have already studied about APLA. We have already studied about APLA, that there are autoantibodies, lupus anticoagulant, and anticardiolipin antibodies which are affecting the coagulant and procoagulant pathways, and these antibodies are responsible for recurrent abortions and multiple thrombi formation. Recurrent abortions and multiple thrombi formation, and treatment is you have to give aspirin plus heparin. Aspirin plus heparin in this case. Now, in this case, antiphospholipid antibody syndrome, there is a criteria. and let me mention you the criteria for categorizing the patient as APLA. Number 1, any abortion of a fetus less than 10 weeks of pregnancy where structurally and morphology it is normal. That means there is no chromosomal anomaly suspected. Chromosomes, if you do, it is normal. Okay, it is not any trisomy or monosomy. Number 2, criteria is abortion occurring more than 10 weeks pregnancy, but cervical length is normal and there is no Mullerian duct anomalies. That means the important causes of second trimester abortion, which is cervical incompetence, you can check it by ultrasound, it is normal. Number 2, there is no Mullerian duct anomalies. So you have already ruled out. Number 3, there can be a preterm delivery of a fetus which is normal. Means there is no abnormality. So this is the criteria for APLA. Okay? This is the criteria for APLA. Okay? And what is the treatment you have to give? Aspirin and heparin. Aspirin and heparin. Color of the amniotic fluid at term, we have already discussed. Pale straw colored. Now, 36 weeks of pregnancy with mitral valve replacement was on warfarin. Her INR is 3. Next step in management. Stop warfarin and start low molecular weight heparin. Stop warfarin and start aspirin and heparin. Continue warfarin and start heparin. Continue warfarin and aspirin. What's your answer? This is the latest question. What's your answer to this question? Yes. So it is stop warfarin and start low molecular weight heparin. Stop warfarin and start low molecular weight heparin. Now, when there is a valvular heart disease, your patient has to be put on anticoagulant. Your patient has to be put on anticoagulant. So, less than 12 weeks pregnancy, you give low molecular weight heparin because heparin do not cross placenta. Heparin do not cross placenta. You can't give warfarin because warfarin crosses placenta and leads to teratogenic effect. Now, from 12 weeks to 36 weeks, you give warfarin because now teratogenicity has been over since organogenesis occurs in the first trimester. Now, after 36 weeks till delivery, you give heparin, and after delivery, again you switch over to warfarin. Now, in the last month of pregnancy, why you are giving heparin? Because it is seen if you continue the warfarin after 36 weeks till delivery, it has caused increased in the bleeding tendencies in the neonatal brain. Bleeding tendencies in the neonatal brain. So that is why here we have to switch over to the heparin. We have to switch over to the heparin. Next, let's take up a long question again. A 35-year-old multiparous lady, I need to revise this question. That's why I'm asking and putting up here again. So 35-year-old multiparous lady went into postpartum hemorrhage after delivery of the placenta. Following steps have been done. With no success, IV fluids 2 liters given, transfused, oxytocin is been given, methergin is been given, misoprostol is been given, and she received 2 units of blood transfusion, but vitals are unstable. Vitals are unstable. What is your next line of management? What is your next line of management? In this case, when so much has been done, 2 liters of fluid is given, 2 units of blood is given, all medical treatment has failed, she is a multiparous lady, so I am not going to do wait and watch because her condition is unstable and your patient will die. Don't save the uterus, save the patient. So it is hysterectomy. Now, 55-year-old multiparous lady, history of frequently micturating during laughing, coughing and sneezing. What is your diagnosis? This is stress urinary incontinence. I have already discussed in yesterday's class. Now, the point which I was not able to discuss because there was so much of content. My question is, if there is a 25-year-old female, she is nulliparous and she has second degree cervical descent. Second degree cervical descent, and there is no cystocele, there is no rectocele. What is the type of surgery you are going to do? Now my options are you going to do Manchester operation? Are you going to do vaginal hysterectomy? Are you going to prescribe her ring pessary? Are you going to do abdominal sling operations? What is your answer? This is from genital prolapse, which we are not able to discuss. 25-year-old nulliparous lady, second degree cervical descent, no cystocele, no rectocele. What is the management? Are you going to do Manchester operation, which is amputation of cervix? Are you going to do vaginal hysterectomy? You are going to prescribe a ring pessary, or you are going to do abdominal sling operation? What is your answer? You can write down in the chat box because such questions are expected from you. See, if there is a new question being asked, many of you are marking it wrong. नलीपैरस प्रोलैप्स में जहां नो सिस्टोसील रेक्टोसील है, हमेशा ही एब्डोमिनल स्लिंग ऑपरेशन लिखना है. व्हाट आर एब्डोमिनल स्लिंग ऑपरेशंस? ठीक है, व्हाट आर एब्डोमिनल स्लिंग ऑपरेशंस? एब्डोमिनल स्लिंग ऑपरेशंस, एब्डोमिनल स्लिंग ऑपरेशंस आर डन फॉर नलीपैरस प्रोलैप्स. इनको सर्वाइकोपैक्सी भी कहते हैं, सर्वाइकोपैक्सी भी कहते हैं. सो ये थे पुराने जो ऑपरेशंस थे, उनको बोलते थे पुरांद्रे स्लिंग ऑपरेशन, शिरोडकर स्लिंग ऑपरेशन, खन्ना स्लिंग ऑपरेशन, और आजकल बोलते हैं एब्डोमिनो सर्वाइकोपैक्सी. ठीक है. आर्टिफिशियल मर्सिलिन टेप इज यूज्ड टू लिफ्ट द सर्विक्स. ठीक है, सर्वाइकोपैक्सी. अगर किसी पेशेंट में एज 50 से अबव है तो वेजाइनल हिस्टेरेक्टमी करते हैं. ठीक है. इफ your patient is 70-year-old female, she has genital prolapse and she is unfit for surgery. तो उसमें कौन सा ऑपरेशन करेंगे? उसको बोलते हैं लीफोर्ट्स रिपेयर. तो इन केसेस में यू हैव टू डू डीएनसी एंड यू हैव टू डू पैप स्मीयर. रूल आउट एनी कैंसर. पेशेंट को कैंसर नहीं है, आपने डीएनसी कर लिया, आपने अल्ट्रासाउंड कर लिया, आपने पैप स्मीयर कर लिया, इस केस में लीफोर्ट्स रिपेयर करते हैं. लीफोर्ट्स रिपेयर का मतलब क्या है? पुट द cervix back into vagina and stitch anterior and posterior vaginal wall. Keep the cervix back into vagina and close the anterior and posterior vaginal wall, जिसको बोलते हैं लीफोर्ट्स रिपेयर. ठीक है, लीफोर्ट्स रिपेयर. नेक्स्ट, 25-year-old presents for routine checkup. She has 2 vaginal deliveries and no gynecological complaint. एक young patient आती है for a routine checkup. She has vaginal deliveries. She had her periods 3 weeks ago, and on examination you notice that there is one ovary which is 5 centimeters enlarged. What is the best recommendation in this young patient? उसकी 2 normal delivery है and she has been having regular menstruation, and you notice that there is one ovary which is enlarged. Are you going to order CA-125 thinking in mind she is having epithelial ovarian tumor? Are you going to do a diagnostic laparoscopy thinking in mind कि उसको कोई कैंसर है? Are you going to put the patient on follow-up? Are you going to order CT scan or are you going to go for exploratory laparotomy कि कोई कैंसर तो नहीं है? What is your answer in this question? This has been a question of USMLE series. It was asked in PG and it was asked in FMG exam. What's your answer? I am happy that you are able to mark gynae questions very well. इसमें कुछ नहीं करना, you just need to put the patient on follow-up क्योंकि उसकी young age है, so most likely it is follicular cyst of the ovary. Follicular cyst of the ovary when follicular fluid failed to rupture. तो इसमें कुछ नहीं करते, just an observation is required. If the cyst size usually shrinks, if it does not shrink, it increases in size, or if it is causing pain or any other symptoms, if you can put the patient on oral contraceptive pills. ठीक है, अगर cyst का size increase हो रहा है या फिर उसको कोई pain है या फिर कोई symptoms आ जाते हैं तो उस केस में आप OCPs पे डाल सकते हो patient को. Otherwise just an observation is required. It is only a simple follicular cyst of ovary. A female patient on antihypertensive drugs comes for preconceptional counseling. Which of the following drugs you have advised her to stop? Which drugs she should stop? Yes, ACE inhibitor, because ACE inhibitors are teratogenic. Next, a primary gravida was brought in the gynae casualty. Brought का मतलब है condition is not good. She is in active labor. She looks exhausted. There is history of thigh handling and pulse rate is 110. She is in shock, 90/50 BP. Uterus is 34 week size. Fetal heart rate is not localized. There is mild contraction. Cervix is 8 centimeters dilated. There is hand prolapse. You can see the hand prolapse. There is cyanosed dirty vaginal discharge. What is your next step? सीधा सा फंडा है, जिस भी क्वेश्चन में देखो दाई हैंडलिंग लिखा है हमेशा आपको सिजेरियन लिखना है. नो वेट एंड वॉच, स्विच ओवर टू सिजेरियन सेक्शन. ठीक है, सो इसमें हमें अल्ट्रासाउंड करने की जरूरत नहीं है, इसमें हमारे को ऑक्सीटोसिन ड्रिप नहीं देना, इसमें हमें एक्सटर्नल किफालिक वर्जन नहीं करना, इसमें हमें इंटरनल पोडालिक वर्जन नहीं करना. ई ऑप्शन में टाइप करना भूल गई हूँ, जिसमें है आंसर इमीडिएट लेप्रोटमी टू परफॉर्म अ सिजेरियन सेक्शन. सो इमीडिएट लेप्रोटमी. ठीक है, नाउ best marker for intrahepatic cholestasis in pregnancy is bile acids. Most common cause of jaundice in pregnancy. Most common cause of jaundice in pregnancy. Important question. Answer is viral हेपेटाइटिस, हमेशा जॉन्डिस का कॉज है वायरल हेपेटाइटिस। नंबर 2 है कॉज इंट्राहिपेटिक कोलिस्टेसिस ऑफ प्रेगनेंसी। नंबर 3 ड्रग इंड्यूस्ड। ठीक है, कॉजेज ऑफ जॉन्डिस इन प्रेगनेंसी ड्रग इंड्यूस्ड। सो सबसे पहला कॉज हमेशा वायरल हेपेटाइटिस आएगा। ठीक है, नेक्स्ट, ऑल ऑफ द फॉलोइंग आर टू बी डन in placenta previa except, this is the question 2021, which is not done in placenta previa: per vaginum examination, ultrasound, clinical per abdomen examination, or blood investigations. I think everybody is right. Per vaginum examination is not to be done in suspected placenta previa. Maximum amniotic fluid seen at gestation age, answer is 32 weeks of pregnancy. We have already discussed. Drugs for medical abortion. Drugs for medical abortion. So it is misoprostol 200 milligram, mifepristone followed by misoprostol. What is mifepristone? Mifepristone is anti-progesterone which inhibits the progesterone support, and misoprostol is prostaglandin E1 which causes contraction and expulsion of the fetus. Best level of anesthesia for cesarean section. This is a question from anesthesia. Best level of anesthesia. ठीक है, आंसर इज T4. सिजेरियन सेक्शन के लिए कौन से लेवल से एनेस्थीसिया चलता है? T4 से. ठीक है, T4. ठीक है, व्हेन यू आर कंडक्टिंग अ पेनलेस vaginal delivery, you go for epidural analgesia. Epidural analgesia, which is the level of block? Level of block, आंसर इज T10 ऑनवर्ड्स. जब आप पेनलेस डिलीवरी कर रहे हो तो T10 ऑनवर्ड्स है. ठीक है, T10 ऑनवर्ड्स. जब आप प्यूडेंडल ब्लॉक देते हो, प्यूडेंडल ब्लॉक किस में देते हो? प्यूडेंडल ब्लॉक किस में देते हो? व्हेन यू वांट टू स्टिच अ सर्वाइकल टियर और यू वांट टू कंडक्ट अ फॉरसेप्स डिलीवरी, तो आप प्यूडेंडल ब्लॉक देते हो. That is S2, S3, S4 at the level of ischial spine. At the level of ischial spine. ठीक है, infant brought to the casualty with dehydration and tachycardia. The genitalia is ambiguous and blood work shows hyponatremia and hyperkalemia. सोडियम कम है, पोटेशियम ज्यादा है, तो व्हाट इज दिस कंडीशन? दिस कंडीशन इज कॉल्ड एज कंजेनिटल एड्रेनल हाइपरप्लेजिया वेयर कैरियोटाइप इज 46XX. इट्स अ मोस्ट कॉमन कॉज फॉर विरिलाइजेशन, सॉल्ट वेस्टिंग डिजीज. ठीक है, कंजेनिटल एड्रेनल हाइपरप्लेजिया हैज early onset and late onset. The most common enzyme deficiency is 21 alpha hydroxylase. So it's a cause for ambiguous genitalia. It's a cause for virilization of the female fetus. 46XX is the karyotype. There is ambiguous genitalia. Ambiguous genitalia means fusion of labia. So you should read about congenital adrenal hyperplasia from medicine. ठीक है, you should read about congenital adrenal hyperplasia from medicine. Which is the enzyme deficiency that is responsible for this? So answer is 21 alpha hydroxylase for part 1. And which is high? 17 hydroxyprogesterone is elevated. This is for part 2. So please read it from your medicine subject. Lining epithelium of fallopian tube. Lining epithelium of fallopian tube is columnar ciliated. Lining epithelium of fallopian tube is columnar ciliated. Which of the following is an absolute contraindication for breastfeeding? Which of the following is an absolute contraindication for breastfeeding? Yes, it is galactosemia. It is galactosemia. A female has previous history of cesarean section, prolonged labor, she is hypotensive, fetal heart rate cannot be heard, fetal parts are palpable superficially. This is uterine rupture, we have already discussed. 25-year-old primary gravida female is on lithium. Okay. For her psychiatric illness for 2 years. Most common anomaly that is seen in the fetus if patient is on lithium. Lithium is contraindicated during pregnancy. Lithium is contraindicated even when the patient is breastfeeding, because lithium is a heavy metal and mode of excretion of the lithium is kidneys. So it causes abstain anomaly. 24-year-old primary gravida has pain abdomen, cervix is 1 centimeter. After 10 hours, the finding is same, fetal heart is 130. What is your management? In this case, nothing to be done. This is, you have to give therapeutic rest to the patient. So sedate your patient. This is prolonged latent phase. Nothing to be done. 24-year-old female, 32 weeks of pregnancy, BP 160 by 116. Okay, so this is PIH. Liver enzymes are elevated. Elevated liver enzymes. There is increase in the LDH and there is low platelet. So liver enzymes elevated, LDH elevated, low platelet. This is HELP syndrome. Next, identify the swelling seen in 22-year-old female. Is it a cystocele? Is it Gartner's cyst? Is it cervical polyp or it is Bartholin cyst? What's your answer? Yes, this is Bartholin cyst. Cystocele is never present in the vulva. Okay, it is a vaginal swelling. Gartner's cyst is again not like this. Cervical polyp is in the cervix. So this is Bartholin cyst. Now, some of the related images. Just see this slide very carefully. What is this? This is Gartner's cyst. How can you differentiate? If you put in a bladder sound, you cannot see the limit. So here the bladder sound, you can see the limit. So this is cystocele. This is Gartner's duct. When you put in the bladder, it does not reach the swelling. So when you put in a bladder sound, cystocele, because it is a bladder neck prolapsing, you can see bladder sound. मतलब simple language में अगर हम bladder sound डाल रहे हैं यूरेथ्रा में, तो cystocele में वो दिखेगी लिमिट और Gartner's cyst में नहीं दिखेगी. That is how you differentiate it by bladder sound test. And ये क्या है? This is cervical polyp. This is cervical polyp. Clear? Which of the following is false positive bar body? What is your answer? This is FMG exam question. Which is false positive bar body? Which is false positive bar body? No. This is Klinefelter syndrome 47XY. So this is false positive bar body. All are true about outlet forceps except. All are true about outlet forceps except. So you should remember the prerequisites of outlet forceps. Fetal head at 0 station is wrong. Fetal head has to be at +2 station and below. Best is when the fetal head is visible in the perineum. It stretches the perineal outlet. So at the time of crowning, you apply the outlet forceps. What is the level of outlet forceps? Outlet forceps are applied at +2 and below. Which of the following is abnormal in pregnancy? This is from Physiological Changes During Pregnancy and Heart Disease in Pregnancy. Can you try this answer? Which is abnormal finding in this case? Answer is diastolic murmur is always abnormal. Split is normal, heart rate increased is normal, but early diastolic murmur is abnormal finding. It is a feature of heart disease. Insulin resistance in pregnancy is caused by all except. Which is the hormone that does not cause insulin resistance? So these three causes insulin resistance, increases the blood sugar level. Okay? Whereas HCG do not cause insulin resistance. Identify the sign seen in pregnancy. What is this sign? Hager's sign. Is it Hager's? Is it Hager's? Is it Goel's? Is it Piscasek or is it Palmer's? Yes, this is Hager's sign of pregnancy. 2 fingers are in the vagina, 1 hand in the abdomen, and you try to feel enlarged uterus between the examining fingers. So this is Hager's sign. Identify the image. What is this? Measuring the diagonal conjugate, obstetric conjugate, or descent of fetal head? Answer is this image is showing descent of the fetal head. Identify the case. What will be the management? What is this case? What do you see? This is a partogram. This is a partogram, and you can see the fetal heart rate. You can see the cervicogram, alert line, action line, uterine contractions. So what do you see in this case? Yes, this is gone into zone 3. So there are 3 zones, and fetal heart, can you see? It was 140, now it has gone into down. So this is fetal distress. Okay, and there is no descent of the head. No descent of the head, and this has gone into obstructed labor. So it is Caesarean section. Which of the following is not a component of Manning score? Manning score is also called as biophysical profile, that is done in high risk. So it is a special ultrasound done in high risk pregnancies where there are 5 components. Non-stress test, amniotic fluid, fetal breathing movement, fetal tone, and gross body movement. So oxytocin challenge test is not a component of Manning's score. Identify the maneuver. What is this maneuver? What is this maneuver? Answer, this is Pinard's maneuver. Breach with extended legs. Breach with extended legs, Pinard's maneuver. Lovsett's maneuver is breach with extended arms. Burn-Marshall technique and Morrissey-Smiley-Viet technique is for after coming head of breach. Okay, so in this case, you can see the Pinard's maneuver. Name the decidua that covers the implantation site. Is the decidua capsularis covers the implantation site. Decidua bassalis is the one which forms the placenta. Decidua bassalis forms the placenta. Decidua capsularis covers the implantation site. Identify the instrument. What is this instrument? Yes, this is Cocker's artery forceps to perform artificial rupture of membranes in obstetrics. It can also be used as clamps when you are doing hysterectomy. Okay, it can also be used as clamp when you are doing hysterectomy. A 35-year-old female has adnexal mass C125 slightly elevated, and what do you see is this image? There is LDH elevated. So what is the tumor you suspect? LDH elevated. LDH is a tumor marker for dysgerminoma. LDH and alkaline phosphatase are the tumor marker for dysgerminoma. Deep transverse arrest. What is the best management? Deep transverse arrest is when the fetal head get arrested as the ischial spine. That means the sagittal suture comes in parallel to the ischial spine. Further rotation and delivery does not take place. This is deep transverse arrest seen in android and anthropoid pelvises. Android and anthropoid pelvises, and management is always a cesarean section. Multiparous with previous to normal deliveries with unstable lie. Unstable lie means the lie of the baby is not fixed. When you have done an ultrasound, it was vertex. After few days, you have checked it has got breach. Then you have checked it has become transverse lie. So lie is not fixed. An important cause for unstable lie is placenta previa, and many times you might have to do a cesarean section if the lie keeps on changing. G2P1A0 presents with full-term pregnancy transverse lie. Cervix is 5 centimeters dilated. What is your management? Whenever a transverse lie case comes in labor, always cesarean section. Transverse lie in labor, any point of time, if it has gone into labor, always your management is cesarean section, because transverse lie baby cannot deliver and you don't know what insult has caused to the uterus. It might be in the process of rupturing. Which plane is the most important in obstructed labor? Most important plane for obstructed labor is mid pelvic plane. Mid pelvic plane is at the level of ischial spine, where the diameter is 10.5 centimeter. Why this plane is important? Because internal rotation of fetal head occurs at the level of ischial spine. So plane of least pelvic dimension at the level of ischial spine is very important, because internal rotation of fetal head occurs at the level of ischial spine. Earliest sign of fetal death is Robert's sign. That is gas in the chambers of heart. Gas in the chambers of heart that is positive after 12 hours of fetal death. Spalding sign is seen 7 days after fetal death. And this is the definite sign of fetal death. Spalding sign is the definite sign of fetal death. All are tocolytic agents except magnesium sulfate is a tocolytic agent, nifedipine is a tocolytic agent, terbutaline is a tocolytic agent, methyl dopa is antihypertensive. So it is not a tocolytic agent. Maternal and child health care indicator gives good obstetric care. So which is the parameter for good obstetric care is always perinatal mortality. This is a question asked in FMG exam. Obstetric care is always determined by perinatal mortality. Perinatal mortality means fetal death. Fetal death occurring after 28 weeks of pregnancy within 1 week of delivery. Within 1 week of delivery. According to WHO, what is maternal death? This is very important question from FMG, and mostly it is the PSM type of question. Maternal death within 6 weeks after delivery. This is called as maternal death. Okay. So annual number of female deaths from any cause related to pregnancy during pregnancy or childbirth within 42 days of termination of pregnancy, irrespective of duration or site. So this is what is a definition of maternal death. Okay, so this is something which is important. Okay, questions part are covered. So I'm just going to quickly show you some of the important slides, some of the important images. I hope this session has been useful to you, because the topics which we are not able to cover up in the classes, I have made you revise. Don't think that the basic topics and points you are not going to revise. Placenta previa, abruptio placentae, that were very basic questions. So some of the instruments that are used in gynae and some of the important key points and slides at the end of the session. Okay. So this is anterior vaginal wall retractor. Yesterday I have asked you an image of uterine curate. So you can see the vaginal wall retractor is to retract the anterior vaginal wall when you're using a sim speculum, and it is little bit, you know, like it is more in weight as compared to the curate. Okay, so it is a tough instrument as compared to the uterine curate. This is valsalum. Valsalum is used to hold the cervix. How can you differentiate it from Alice tissue forceps? This has got an angle like this. Okay, so you can differentiate. So you're holding the anterior lip of the cervix when you're doing uterine sounding, you're doing endometrial biopsy, you're doing a copper T insertion, you're doing intrauterine insemination, or you're taking the cervical biopsy. That is the use of valsalum. Now this is colposcopy. Colposcopy is visualizing the cervix, and you apply acetic acid and Schiller's iodine when you want to take a colposcopic directed cervical biopsy. This is ovomatry forceps. Ovomatry forceps does not have any lock, and you use it to remove the products of conception in case of inevitable or incomplete abortion. This is sponge holding forceps. Most of the time when you are doing cleaning and draping, you are using the sponge holding forceps. You hold the sponge and doing the cleaning of the abdomen or any of the area where you want to do the surgery. This is Cheetle forceps. Any instrument you want to take up from the sidex, we are using the Cheetle forceps. This is uterine sound. When you're doing MTP, you want to check, or you are doing a copper T insertion, you want to check the uterocervical length. So uterine sound is used. This is Doyne's retractor. Doyne's retractor is when you're doing the abdominal surgeries, you want to retract the urinary bladder, Doyne's retractor is used. Yesterday's slide, I have shown you the Dever's retractor, that is to retract the liver, spleen, mesentery. This is to retract the urinary bladder. So this instrument is used while you're performing a cesarean section, hysterectomy, laparotomy, tuboplasty, any sling operations. This is episiotomy scissors. In the AIMS PG exam, this image based question was asked. This is hysterectomy clamps. You are applying this hysterectomy clamps. It has the corrugations like this to hold the pedicles. This is Leash-Wilkinson cannula to perform HSG. You are injecting a dye into the uterus. This is uterine hook to remove misplaced IUCD from the uterus. This is living ligature. Living ligature is arrangement, crisscross arrangement of muscle bundles around the blood vessels. So this muscles contract and it occludes the lumen of the blood vessels, hence minimize the blood loss. This is the natural mechanism to control the bleeding in third stage of labor. Living ligature is present in the middle layer of uterus. Active management of third stage of labor, you can see in this image, the placental delivery is being conducted by controlled cord traction method. So oxytocin is given, controlled cord traction method is used, delayed cord clamping is done, but uterine massage is not a part of third stage management. Filamentous insertion of placenta, it causes vasa previa when umbilical cord is attached to the fetal membranes. This is subcenturita lobe. It causes secondary PPH. This is battledore placenta. Umbilical cord is attached to the margin of placenta. This is diagonal conjugate. This is diagonal conjugate. टेलीग्राम लिंक पोस्ट कर दो चैट में, दोबारा कर दे एक बार पोस्ट चैट में. Increase in pregnancy. What are the parameters that increase in pregnancy? Is cardiac output, and cardiac output is maximum 70% in immediate postpartum period. Plasma volume reaches maximum 40 to 50% during pregnancy. Clotting factors increase during pregnancy and total proteins increase during pregnancy. You have to revise this. Then what are the parameters that decrease in pregnancy? Platelets, blood pressure and clotting factors 11 and 13. Most common cause for first trimester abortion is chromosomal causes. Most common cause for second trimester abortion is cervical incompetence. Okay, so you can keep on revising the important points. Some of the important key points and images and instruments I am adding up in today's session. So provided that all other part you have revised. एक बार बीम chat box में post कर दे group. Threatened abortion, we can save the pregnancy, check the fetal cardiac activity on ultrasound and give the progesterone support. This is very commonly asked question. Uterine anomalies is a cause of recurrent abortion. Most common uterine anomalies causing abortion is septate uterus, and next is the bicornuate uterus. Branches of uterine artery in the uterus is ARBS: arcuate, radial, basal and spiral. You can see arcuate, radial, basal and spiral. So Bhim, the coordinator of this online NLC group, he's already shared my Telegram group. You can save this Telegram group and you can just join using this link. And today's PDF, the answer key, the key points, all this will be posted after the session in my Telegram group. You can see from that. So this is Chadwick sign, bluish coloration of the cervix and vagina. This is external cephalic version being performed in breech presentation. This is the physiology of lactation, and I have told you, just remember, mammogenesis is done by estrogen and progesterone, but there are adrenal steroids, growth hormone and other hormones also causing mammogenesis. When it comes to lactogenesis, main hormone is a prolactin, but thyroid, growth hormone and steroids also causing lactogenesis, and oxytocin causing milk ejection reflex. So this slide is important. In 2020 exam, question being asked, growth hormone causes mammogenesis. Supine hypotension syndrome, I have already explained. What are the normal changes of the heart in pregnancy and abnormal? Remember split S2, diastolic murmur, ejection systolic murmur grade 3 or more, and raised jugular venous pressure and cardiomegaly. These are abnormal findings in heart disease. Normal findings is apex B is shifted towards left, split S2, ejection systolic murmur up to grade 2. These are the normal physiological changes. This slide is important. Please go through this slide. I am going to post this in the Telegram group. टेलीग्राम लिंक लिखा तो हुआ है, डॉक्टर हरमीत गोयल के नाम से है. आप ये लिंक यूज करके यू कैन ज्वाइन दिस टेलीग्राम ग्रुप. लिखा तो हुआ है t.me, ये मेरा टेलीग्राम ग्रुप का लिंक है. यू कैन सेव दिस एंड यू कैन ज्वाइन यूजिंग दिस लिंक. This is outlet forceps. This is Piper's forceps. After coming head of breech, Piper's forceps are used. Cutoff value for hemoglobin to label it as anemia in pregnancy. WHO less than 11 gram%. According to India, it is 10 gram%. So I hope the 2-day session on the YouTube live, the gynecology and obstetrics have been useful to you. please do revise the content just before the exam. So you have got more than 1 month to revise. Okay, so hope this session is useful and you are going to get full out of full marks in obs and gyne. Stay connected with me and you can ask your queries on the Telegram group. I am always there to help you out. Okay, so bye bye. One-liners I am posting in my NLC group. I like the smileys of Dr. Ashish, Shagufta, Bharat, Avdesh, Akshay. Okay, Rahul, thank you so much. Thank you so much. The crowd has been really wonderful and I am really liking your words of appreciation. Teacher is always overwhelmed when the students are able to get full out of full marks in the particular subject. आप टीचर के पर्टिकुलर सब्जेक्ट में अच्छे मार्क्स लाते हो, सेशंस यूजफुल होते हैं, तो हमारे लिए भी एक एनर्जेटिक मोटिवेशन होता है. So I really like your smileys, wonderful group, all the best, very very sincere group. So bye bye. Yes, dosa party, thank you. We will soon see you. और आपको थोड़ा एक्सटेंडेड टाइम मिल गया है, रिलैक्स नहीं होना है, करते रहना है, सारे सब्जेक्ट्स को अच्छे से करना है. बाय बाय.